Welcome, Yalimadut. Good evening. On behalf of the Aga Khan Health Board for Canada and the Care for the Elderly portfolio, I would like to welcome you all to this evening's webinar entitled Transitioning to Assisted Living and Long-Term Care, Recognizing the Early Warning Signs. My name is Saifa Sidi. I'm a volunteer with the Aga Khan Health Board for Canada, and I will be your moderator tonight. It is absolutely amazing to see how many attendees we have. So thank you so much for joining us. We have a packed agenda today. We will have a formal presentation for about 45 to 50 minutes. And what we'll do in that 45 to 50 minutes is we will have some questions in between. I will ask those questions. And at the end of the formal presentation, we will have about 10 minutes for the audience Q&A. And I would like to request that if you can use the Q&A box, you'll see that at the end on the bottom of your screen, the Q&A box to submit your questions. And it is my honor and my privilege to introduce and welcome tonight's speaker. Dr. Naheed Rajabali was appointed as faculty member by the University of Alberta. He received his training in internal medicine and geriatric medicine at the University of Alberta. He primarily works at the Royal Alexandra Hospital in Edmonton on the acute inpatient ward and consult and geriatric emergency medicine consult service. He had delivered care at the Parkinson's disease and movement disorders program at the Kaye Edmonton Clinic in collaboration with the Department of Neurology from 2017 to 2022. He is particularly interested in devising approaches to tailoring care across various disease settings, particularly in the perioperative setting, and he also enjoys teaching. That's why he's here today. And without taking up any more time, I'd like to pass the baton to Dr. Rajabali. Over to you, Naheed.
Well, thank you very much, Saifa, for a warm welcome. Thank you to everybody participating. Let's get started. So today's objectives will be looking at what healthy aging looks like. So we have a good understanding or a good baseline. We're going to get a good appreciation of physical and cognitive reserves or brain functioning. At the same time, we're going to look at the actual dysfunctioning of physical and cognitive aspects in aging. We're going to look at different levels of care for supportive living. And particularly, we're going to look at early warning signs for increasing care needs. We're going to look at strategies to avoid or delay requiring supportive living, and if required, to avoid having to do so in a crisis situation. We're going to address caregiver stress. We're going to address looking at imminent warning signs. And then what happens when somebody is already at the hospital and then has to transition to supportive living. So, but first, what does a physician who does geriatric medicine do? So this is, my scope of practice. So we have an understanding of disease and disease management. So in the case of mine, we manage anything from, heart failure, COPD, issues with kidneys, sepsis, and even looking at preoperative assessments. And then we have an appreciation for somebody's functional quality of life. And so we have additional training in things like behavioral neurology, movement disorders, Parkinson's, psychiatry, rehabilitation, something called geriatric syndromes, issues with things like pain, incontinence, etc. And then beyond functional quality of life, some people have residual functioning. We appreciate that there's a human being behind that person. And so to help with dignity, we have additional training in things like palliative care and the management of very, very frail patients and assessing their capacity. So all of this kind of helps us tailor care. It helps us promote healthy aging. And we're certainly not age-based, we're concept-based. So we have in my practice seen patients who are quite young as well. Less than 65. Now, to get back into the topic of transitioning away from home, when people or loved ones have to go elsewhere or have care needs that are increasing, and one has to potentially consider this, they have to look at either something called independent living, assisted living, or long-term care. These are general terms used across Canada. Provinces and cities may have specific terms for each one of this, but these are the general terms. But transitioning away from home can often be quite sensitive of a topic. It can be heartbreaking. There can be a lot of guilt, resentment that brews into the process. And it can be quite traumatic if it has to happen in a crisis situation. However, if you recognize the signs of what it may take to transition, you may be able to plan early, get help, facilitate a smoother transition, perhaps even avoid it altogether, and minimize any negative experiences, and then turn this situation into a potentially positive or hopeful experience. So let's look at what healthy aging looks like first. So when we talk about healthy aging, we refer to physical and cognitive, or cognitive meaning brain functioning. It's important to recognize that healthy aging means that you are still capable of functioning well. You can still play sports, you can still, and in the case of many people, go to school at a later age. You can paint, you can garden. And if we have that appreciation for healthy physical and cognitive aging, when we see things that are not heading that way, we can see those things as early warning signs and hopefully do things or intervene in a way which may prevent further decline and needing more supports. So the idea is not to normalize disease and aging, which seems to be sort of the norm. We need to move away from that. Of course, there's also healthy aging that goes beyond the physical and cognitive aspects of the human. There's a quote by Rumi, it says, "My soul is racing ahead of me. It says that the body is too slow for me. I am going." Of course, this dimension of the human, this discussion is beyond the scope of this talk. We're going to focus on the physical and cognitive aspects of aging or healthy aging and dysfunction in those areas. So disease and dysfunction are not normal parts of aging. And you can have dysfunction in your physical nature. So if you have, if you slow down, but then are starting to need help with cooking and shoveling and etc., that's not normal. And often this process of physical decline is accelerated by a chronic disease, heart disease, lung disease, cancer, Parkinson's, etc. Then there's also dysfunctioning in the brain, the cognition. And there's many contributing factors. It's not normal for aging, never. It used to be normalized, but we know better now. So having, something like Alzheimer's or another neurodegenerative process like Parkinson's can cause this. Having a stroke, some people don't return back to normal after some strokes. Cancer, long-term alcohol use, traumatic brain injury. All of these things can lead to brain dysfunction. And there's also then psychiatric issues, the common ones being major depressive disorder, bipolar, schizophrenia. And then in between, you have something called behavioral and psychological symptoms of dementia, or BPSD. They're not quite your primary psychiatric disorders, but they're the ones related to dementia. It's when your brain starts to, as a result of dementia, get agitated, aggressive, see things that are not there. So that's what these things are. Now, why is this important to appreciate? Well, it's important to appreciate that these issues of dysfunction are not exclusive to older age. You see, chronic disease in Canada and other parts of the world is starting to increase in general, and it's shifting to younger Canadians. And as we saw in this slide, chronic disease adds to dysfunction. So if it's starting to happen a lot more in younger people, you start to see these problems of dysfunctioning almost at any age. So now we're seeing it in people in their 60s, early 50s, sometimes even 40s. So it's good to recognize these things are early warning signs, even in younger age these days. There is an interrelatedness of diseases and lifestyle. So there's always a genetic component to dysfunction. If you're born with an issue, Then there's environmental issues. However, a big component of it is lifestyle. So physical inactivity, nutritional deficiencies, smoking, alcohol, which lead to then changes in the molecules of the cells and within the cells and outside of the cells, whether it's inflammation that's not good, or neuroendocrine or other molecules that are present that are not good. And all of these then tend to sort of be a common pathway for many of the common diseases that we see: heart disease, lung disease, cancers, dementia. So in a way, they're all interrelated. And they may have their own individual symptoms, but they all then lead to what we call diminished reserves. They take away from your reserves, your ability to withstand any stressor that comes to you. So whether it's having another acute disease or a surgery or having trauma, your reserves are less, so you're impacted more. And then that in turn leads to dysfunctioning or increasing care needs. There's an interrelatedness, and this is important because understanding this can also help us look at ways to reduce the possibility of getting to that stage of needing help. This is yet another diagram that shows the relationship between physiological reserves and aging. So successful aging, of course, in normal aging, you do lose a little bit of your reserves just because aging in nature is like that. But in general, you should never be disabled as a result. You need to get away from that. In accelerated aging, because you may have a chronic disease on board, lifestyle choices are not great, okay? You may then get into places where you become frail, where you have low reserves, or what somebody says sarcopenia, loss of muscle mass, which is also another indicator of diminished reserves. And eventually you can lose your independence. You have dysfunction.
Naheed, I have a question for you.
Yes.
Is there a way to increase your reserves? Because you talked about diminished reserves. So I kind of see reserves as maybe your part of resiliency.
Yes.
Is there a way to increase your reserves?
Yeah, there's a way to reduce the rate of decline. I think nature will always, at some point, make us lose our reserves to some extent, right? But if the question is, how do you get to this, where you can still play basketball should you choose to? Maybe your 90-year-old version will not be as competitive as your 30-year-old version or 18-year-old version, right? But or still be able to graduate from school should you choose to go back in your 70s. Yes, there are things that are emerging that are showing they can do that. And it all comes back to this. There's emerging evidence that exercise, and beyond just a walk in the park, but true rigorous exercise when you're capable of doing it, actually changes the molecular nature of your cells and so on to be protective. So that's one. The second, are things like diet. In the North American diet, we have too much intake, and that's showing to be a problem molecularly. So, the type of diet, the amount we take, that now is starting to emerge as one factor that can be protective towards becoming frail. And of course, things like consumption of, habits of things that, like alcohol and smoking and other things that have shown to diminish reserves, reducing or cutting intake of those things can help. And believe it or not, even things like meditation, those things are emerging protective factors that are showing signs of, there's evidence that those things can protect brain function. And things like volunteering, they release chemicals in the brain that can be protective. So excellent question, Saifa. Yes. So there are things that can be done, but you don't want to wait till it's too late to consider them. They sort of need to happen early or before the early warning signs. And we'll talk about those. So we talked about cognitive reserves or brain functioning. And let's not get into the nitty-gritty of things, but this is an example of something we use when we look at reserves or cognitive reserves. Okay. So the global deterioration scale is one item that I use at work when we need to tailor care. But you can have things like mild cognitive decline, forgetting names, and then having issues with traveling to new locations and traveling to locations you're familiar with, difficulty handling issues at work. Of course, you have to rule out other things, like thyroid issues and so on and so forth. But when it's truly an issue with cognitive functioning, this is what it looks like. Having issues with managing finances, medications, cooking, And as it gets more and more severe, then you have difficulties with remembering how to put your clothes on or how to bathe or remembering what happened 5 minutes ago. And at each of these stages, there are different things that can be done. But the important thing to appreciate is that our reserves, it's not just a flick of switch where you lose your reserves. It is a gradual process. Unless, of course, you get like a big stroke or a big trauma to the brain, then it's a different story. But more often than not, it's a gradual decline in reserves, and it does happen, and that's not normal. Then we look at something called overall reserves, cognitive, physical, all that combined. Again, I use this tool in addition to others to help tailor care, what we're going to do for somebody's heart failure, how aggressive to be, what kind of surgery to do. But we also look at it or use this tool when we're deciding how to help somebody, with their life. So the green sign is, early warning sign when people become vulnerable or slow down. And in these situations, you have to not just say it's aging, look for a potential problem, ask your doctor, are they having something? Are they becoming anemic? Are they developing Parkinson's? Is there a cancer brewing? Don't take it for granted that it's normal in aging to just suddenly slow down or being tired. And then there are a bit more warning signs or earlier warning signs when people start needing help with some of the what we call IADLs or instrumental activities of daily living. So things like day-to-day things like finances, driving, medication usage, etc. Heavier housework like laundry. If they were able to do it 5 years ago and now they're having troubles, that's a warning sign in itself. And then when things get a little bit more imminent is when people start needing help with even the more basic activities of daily living, which are things like bathing, toileting, difficulty climbing stairs, and so on. And anything beyond that is a bit more of a early, an imminent warning sign, which we'll talk about. So putting it together, everybody has a set of reserves, which can be seen in the way they function. And then there are stressors that can test those reserves. So if you are robust and fit and you get a stressor, whether it's a heart attack or something, or a car accident, whatever stresses your system, you will likely recover better. But as things become progressive or you start off with fewer reserves, you don't quite come back to where you were before. And eventually some people become dependent or disabled. Now, there are levels of care that can help with every stage of a person's reserves or functioning or dysfunctioning. In Alberta, we call it continuing care. There may be similar terms in other provinces, but the levels are fairly similar. So if you are independent, managing your shoveling, but you slow down, usually it's not a problem because you can still take care of things. So one doesn't need to consider supports or going to supportive living or moving away from home. That begins when you start needing help with things like meals, cleaning the house, whether you're physically weak or because you have dementia. If you're lucky enough to have supports, you may stay home. But if you don't, this is when people start looking at things like seniors lodges or independent living facilities, or they may be able to get away with it with just home care. But usually it's at this time people start looking at things like independent living facilities, which help with meals and so on. When you start becoming what we call moderately frail, needing help with your basic activities like bathing and showering, whether it's because of your physical limitations or because of dementia, you can't figure out how to do it, then people start looking at supportive living or designated supported living or assisted living, and there's different levels. Now, again, if you have caregiver support at home, spouse, family, and maybe home care, some people don't need to, but it's still a looming problem. And for people who can't, they need to start considering assisted living. As their care needs get more and more, and caregiver strain increases, then you start looking into higher levels of supported living and eventually long-term care, where all of your needs, even feeding, needs to be taken care of. So these are different levels. This is pretty much a reiteration of that. You have independent living, meals and cleaning provided. You have the different designated sites. Essentially, these have all either like healthcare aides that are there 24/7 on site. As you need more help, you get licensed practitioner nurses that are there 24 hours, 7 days a week. With more needs, you may need an RN, and in long-term care, you have everybody involved. And that's, really under the assisted living blanket here. There is a supportive living for dementia, specialized dementia, where you don't have too many physical needs. You can still walk around. However, you're wandering or you get agitated, and there's a special assisted living for that. Usually we call it a DSL4D in Alberta, or a dementia unit, or dementia assisted living. So it's good to know that. Now,
and in Ontario, they also have in long-term care facilities, they do have behavioral support units or dementia
Right.
units where sometimes they're separated from other patients, and sometimes they're with everybody else. But many homes have separate dementia units or separate behavioral support units because their needs are different.
That's right.
And so I guess it's similar to that, where it is designated and they are separate and tend to be, usually separate from the rest of the patients.
Right. Very good point, Saifa. So yeah, so there may be some variations, but generally these are the sort of different designations or different settings. Thank you for bringing that up. Okay, so moving to the earlier warning signs, or the green yield sign, right? So who has early warning signs? Well, first we look at individual characteristics. So who are at risk? Individuals with disorders or issues from childhood or early adulthood. Those disorders or problems often can progress, putting them at a higher risk. It may not be a problem now, but it's something to keep track of. Individuals with chronic diseases, especially those with multiple chronic diseases. So they have heart issues, lung issues, diabetes, kidneys. Those are the type of people who will likely progress. So you have to keep an eye. Poor lifestyle, sedentary, you don't do anything. And then, other lifestyle choices. Physical trauma or injury that's lasting. So if you've gone to a car accident and you've had spinal problems and you have difficulty walking, you have chronic pain, that's an example. People who are starting to require assistance for functioning. So, driving is becoming a problem. Getting to the doctors is becoming a problem. That's, people look at. And a strong family history of certain diseases like Huntington's. Often, we call, these are autosomal dominant. So it's when somebody has this disorder, it's likely their children will get it, and they deteriorate quite fast. So this is just one example. And what do you do in this situation? Well, listen, I think it's imminent at this point for most people. But it's a good time to have, what I call a courageously sensitive discussion. So you have to have a discussion around these sensitive topics. So there shouldn't be any guilt or shame. There's plenty of time to talk about it. But say, hey, look, in 5-10 years, or in who knows, if these issues arise, we need to start thinking about, can we get help? Our finances, are they in order? Or do we need to look at supportive living? Okay? It's a very touchy subject, but it's an important one that needs to be done. This is where you can modify lifestyle. And Saifa asked that question earlier on, so I won't get too much into it, but this is a chance for you to potentially help that trajectory not go down so fast. You could potentially, have a race against time, perhaps, and maybe you'll pass away before you need help, right? But which are what people's goals are. But this is your chance. So you can get a personal trainer. If you don't know how to exercise, many people haven't done it in years or ever, to be honest. They've probably worked their whole lives and they have no clue how to exercise. So get a personal trainer or a physiotherapist, right? A dietitian to help you. If you need rehabilitation because something's aching, get rehab. We talked about meditation, volunteering, monitor progression, seek community supports and advice, and advocate for a loved one or for yourself and tell, your doctor or whoever else, this is not normal. I'm slowing down. I'm in pain. Surely this is not aging. I've heard so-and-so say it's not healthy aging. I want to do better. Okay. Get a personal directive and power of attorney as well. Now, moving to early warning signs. These are the ones you need to take heed to a little more. So this patient or loved one specific problem. If they're starting to require help with, heavier, things, or not necessarily heavier, but they're starting to need help with medications. And there's not as many caregivers around, for example, right? or they need help with uh, cleaning the house. This is an issue. Or they're forgetting to make meals. This is a problem. If they need help with bathing or dressing, or someone needs to stand by just in case, or because of dementia, they need to be told all the steps. Okay, you need to put your leg in now. You need to dry yourself. All those things that take lots of steps. Those are early warning signs. If they're unsteady, especially while using a walking aid, if they've experienced falls already, if they have worsening medical issues, so they need hospitalization because their heart failure keeps coming up, or their COPD issues keep coming, or they are palliative, they have cancer, and there's no cure at this stage. So we know the trajectory is going to be, going this way, down, right? They're going to need more and more help because their reserves are being chewed up or eroded. If because of dementia, they're developing new behaviors or personality issues, they're becoming more and more agitated, upset with you, aggressive. This is not who they are. They're making up stories. They think somebody is going to steal something from them. They're wandering. They're trying to leave the house at 11 p.m. Okay, and if they have psychiatric issues like bipolar or schizophrenia that are existing, but they're starting to become more of a problem, this is it. So other factors, we talked about caregivers. If you know somebody who doesn't have a caregiver, maybe they're in the hospital, maybe they've passed away or they've never had one, and they're having these issues, this is concerning. If you know as yourself as a caregiver or somebody else is trying to feel stress, you can see it when you see them. They tell you this is a problem. If there's limited supports, and typically this happens, patients who are or loved ones who are in the rural areas where they're generally just fewer supports, right? Compared to urban. If there's no fixable medical issue, talked about a little bit, and if they have limited finances to be able to have private care or something else, okay? Those are people who have early warning signs. Those are early warning signs to take heed to. So what do you do in this situation? Well, if you're a caregiver and you're contemplating getting more help, or maybe even saying, gosh, this loved one may need to go to a facility that's not home, okay, or a seniors lodge or independent living. First and foremost, don't carry that guilt. It's actually a good thing to consider. Okay, and I know sometimes in some cultures, that guilt can be even more, but it's important to not feel guilty or think that you should have something to be guilty of to even think about this possibility. Secondly, engage in social and community supports. Every province has, home care or home care equivalent. There's a case manager. Engage. There's social workers out there that can help. And this, I cannot stress. We in our community have, what was formerly known as MAS or Medical Advisory Services. Now it's the HNS, the Health Navigation Services is a new name, or the Access Line, part of the Health Board. They are very helpful. I used to be a part of this before the name changed a while ago, and I can tell you they have professionals in there. They maintain their professionalism. There's confidentiality, utmost professionalism, care, compassion, and there's a personal sense of wanting to help. And they will do their best. I've seen people do it. It's a great resource. Use it. Okay. Seek proper consultation with your family physician. If there's a specialty specific problem like in Parkinson's, get a Parkinson specialist or ask them. Okay. Geriatric medicine, it's a specialty. Your family physician can refer to them. You can often advocate and say, you think you should see a geriatrician, you should do that. Geriatric psychiatry or psychiatry for psychiatric issues. And then there's a very interesting specialty called physiatry, not psychiatry, but physiatry or physical medicine and rehabilitation. People often don't know about them, but they deal with things like musculoskeletal problems, hip and back issues. If you have pain, that's shooting, and you can go on about what they can do. Remember this name, Google it, but they're often referred to, in my opinion. Maybe there's somebody here that's a physiatrist that may disagree, but it's a good specialty to consider. And then the other thing is plan for, I said ALC here, but plan for supportive living, plan for the possibility. If the care needs rise, get a personal directive and power of attorney, get support, set a threshold or a red line. You talk to a loved one or yourself or family, say, at what point do we for sure have to consider either getting maximal help if we can, or consider having the loved one move out of the house to get care, the type of care that he needs somewhere else. I would suggest you do that. Again, it's a sensitive topic, but it's very important. And remember, the transition that you may seek to go somewhere may not happen on demand. So just because tomorrow you might say, this person's falling now, I can't manage, it's very hard. Tomorrow, they will not necessarily go somewhere. They may end up in the hospital or injuring themselves before they need to go somewhere where they can be cared for. Okay, misconceptions. First I find I did this presentation, she talked to me, she said, gosh, I've heard some people say, why worry? We're going to die anyway. What's the big deal? Some loved ones say, why do this? Why even worry about this problem? What's the big deal? Hakuna Matata, what's the fuss? Which is true, but you tell them you're taking a gamble, because everybody, of course, wants to pass away peacefully without burdening themselves or anybody else. The problem is, a quick passing away before challenges set in or disability set in isn't guaranteed. So it's good thinking, but it's not always possible. So these are the reasons for promoting healthy aging, but also recognizing early warning signs and being proactive, even with stubborn loved ones. Okay. So caregiver stress, these are often unsung heroes, the caregiver. They probably burden so much more than we can appreciate. When does caregiver stress arise? It's usually when the caregiver themselves are looking after something else, whether they're working employment, they need to pay the bills, you can't just take time off, right? If they're looking for multiple people, some people have multiple people they have to look at, whether it's their own children with disabilities or their parents, multiple parents, siblings. They have their own personal health issues that they have to take care of, their own doctor's appointments to get to, and then they have to manage their loved ones' issues, and then it becomes quite a bit of a task for them to be able to manage. There's no time for self-care. Anybody who's had to do lots of work continuously and stress about this and stress about that without any break, you're going to break, or there's a likelihood of it, right? Patient expectations. I call everyone patients, but a loved one who's in need, they may want everything done for them. They may not have a good understanding of how much burden their caregiver is having. And of course, there's, in some cases, family expectations or pressures. So sometimes a caregiver may have family members, especially residing elsewhere, who don't have a good understanding of what's happening, on the front lines, that's happening at home. And they may say, come on, keep him home. You're not trying hard enough, or those may be insinuated. And they may add a bit of guilt or resentment, knowingly or unknowingly, but that's caregiver stress as well. So I stress that even despite all this, it's very important to make sure that you do consider supportive living. Because if you're trying to do it on your own, there's gaps in the patient's care. There's gaps in the loved one's care. And what does that what happens? Well, I'll tell you what happens if there are fewer gaps, or if you can transition somebody to getting more help or into a place that they need to go that's going to match their level of care without you burning out, okay? So if you have fewer care gaps, there's reduction in death and morbidity, so falls and other injuries and illnesses. There's a reduction in delay in receiving appropriate treatment and support. There's less frequent visits to the emergency department. There's prevention of readmissions to the hospital. There's decrease in emotional and physical pain for loved ones or patients, their families, and care providers in general. So those are all good reasons to consider a smooth transition and not to hold back. Now let's talk about imminent warning signs. So these are the ones that are, when you're in your car, the dashboard lights up. Now I know some people ignore the warning sign on the dashboard, but if it's the one that has a red coming through, that you should make sure you get that one checked right away, right? Maybe you want to pull over and get help. So loved one or patient-specific issues, if they start needing help with needing one person or two people to get up, and you're by yourself as a caregiver, even with two people, this is not going to be sustainable. This is already a marker of things going to be declining quite fast. If they need way more cueing, now for single steps, this is how you put the spoon in there. Now bring it to your mouth, right? This is not going to be sustainable. The caregiver is going to burn out. and the problem's only going to get worse. Frequent falls, progressive weakness and imbalance. Even if they're using a walker now, they're starting to look wobbly. That's problematic. If they're impulsive, not using a walker or the walking aid because they just forget, and that people with dementia, they do that. If they have poor insight or judgment, you're helping them, they have no idea what their care needs are at all. That's a problem. If they have recurrent hospital visits, safety issues, they're leaving the stove on, tap on, all these things are happening. That's a problem. And if there's challenging behavior and personality issues, now they're getting violent and aggressive. They're hitting, they're threatening. They're becoming difficult to redirect before you can calm them down, give them soothing words, maybe some chamomile tea, all these little things, but now those things don't help. And then they're wandering dangerously. It's minus 35 and they're already out the door with one sock and no shirt, something like this, right? That's a red flag. So again, when is it also a red flag? When there's no caregiver. So sometimes a caregiver still tries to burden this, but they themselves end up in the hospital or they pass away and they've completely burnt out. Things are imminent at this stage. When you already have maximum home care supports, the government or case manager says, look, we just can't do anymore. And you're feeling strained. That's a problem, imminent. Something's going to happen in the next month or so, or maybe even the next week. Limited supports, no fixable medical issue, and of course, limited finances. There are some people that can afford to get, 3-4 people privately. Essentially, they're housed into a long-term care. They can get their long-term care beds. Not everybody has that capability. So, okay. So what do you do in this situation? Again, number one, reduce a sense of guilt if you're the caregiver. It's so important that you move away from that thought process. Then you focus on getting the right help urgently. So call your case manager. Listen, what can I do? How do we transition this? They usually have strategies. Social worker can help. Some people may need a capacity assessment. So if a caregiver has such poor insight that they're saying, I don't want to go, yet it's very obvious, then it becomes a question to whether they're making a bad judgment or they're making an uninsightful one. For that, you have to do a capacity assessment. Home care case managers can help you direct to that. There's palliative care. They can often come to your house and manage somebody there as well. And then as a last resort, sometimes it's the hospital. But I say don't use that as a safety net in your minds because it's not a pleasant environment if you don't need acute help. It's loud. You can get germs. It's not a very dignified space to be in, to wait to get into a facility. So don't wait for that, as an option. Luckily, we do, well, for better or for worse, most people don't fall through the cracks because it is, but don't wait for that. So what happens now?
Question for you, whether you want to do it after this slide or after the next slide, is if you're in the red zone, is there a way for you to move into the yellow zone or the green zone? So take your trajectory the opposite way, where you're instead of red to yellow to green, where you're getting worse, you're actually going the other way. So is it reversible? Is any of this reversible?
Sure. It depends on what issue. So let's just say some people have very challenging behaviors, but it hasn't been addressed because the right person hasn't seen the patient or a right specialist hasn't, right? Or, people often say, well, this person's becoming angry. That's just how it is with aging. People get like this. In these situations, if you manage, there's ways to manage these behaviors, with medications and other strategies that will often put you back into the, at least the early warning sign. I wouldn't say put you back in a green zone, but it buys you more time. If they're wandering, there are strategies that home care can potentially give you, right? There's wander guard, there's ways to kind of adjust your locks and do other things. That will buy you some time. And it may be for the longest time. Someone might be able to be passed away dignified in their house with that strategy, or it may just give you a little more time before you consider a more smoother transition. So yes, for some things.
And who should be part of your care team, or who should you go to help you devise a strategy? So, for example, like you mentioned, the example you gave where you're like, these not aggressive, but maybe not normal behaviors is part of the aging process. This person's aging, it's okay, but maybe it's not okay. Maybe it's part of their disease state, right?
That's
So
right.
who would you need to go to get help to find the right resource to diagnose
Okay.
that or to provide treatment or advice or whatever?
Yeah, that's a good question because this particular problem is becoming a big problem. It's becoming a huge problem. So behavioral changes, first of all, never normal in aging. Never normal to become socially withdrawn, never normal to become aggressive, agitated, make up stories, see things. Never normal. So when it starts, you got to do something about it. Your first step, as always, is your family physician. And I know there's some people that don't have one, but it's your first step. Make sure you get one, and then you advocate and say, "This is not normal. We've heard." Of course, your family physician should know that this is not normal. But if you want to advocate some more, there's maybe some resistance. You can say, "Look, we are requesting a consultation from either or both a geriatrician, okay, or a geriatric psychiatrist." And in Edmonton, we often have either services that can, you can go to the clinic and see them, or there's ways that they can come to your house and do an assessment. So ask about those things. Say, can we have somebody? Often home care case managers will know some of the resources because they often work closely with some of these other resources. So they know, they have the experience, they've seen a range of issues, right? So the second then person, or at the same time, is get a case manager. And I think you can get them without even needing a referral from a family physician. You can often call, and say, "Look, I'm having this issue. Can we have a case manager come in and do an assessment?" And then you can also call the navigation, the health navigation services, right? Formerly known as MAS, and they can help you navigate. They have specialists in there, and they can help navigate. I know because being part of it, but also helping when somebody asks me for advice, they do look around for things. So I would say those three things are your resources, your first resources. Yeah, good. Now, inevitably, some people will end up in the hospital, even despite your best efforts. There's no shame or guilt that should have in any of these situations. So how do people end up in the hospital and then eventually need help transitioning to supportive living? What are the roots? You can have high reserves, be fit, play basketball in your 80s or 90s, or even in your 40s, doesn't matter. But you can have then a severe acute illness. So all of a sudden, for whatever reason, a bleed in the brain, an aneurysm, okay? Or you may have a cardiac arrest where your heart stops, you don't get enough oxygen to the brain for long enough that your recovery is not anywhere close to where you were before. Now you need help. Okay, you may have amputations, etc. The other way is you already have low reserves, physiologic reserves, and you have an acute illness like a urinary tract infection. It could be a minor problem. But if you have low reserves and a minor problem, then it takes up more reserves and you get to that point where now you have even more disability. And maybe going home now has become a challenge because of caregiver strain, not enough supports, and it's difficult. You can have low reserves and not necessarily any acute issues, but then you're gradually going down, right? You're falling, you can't get up, or you maybe can once in a while, but it's becoming more and more consistent that you can't. And then you can't cope, your house is in a disaster, okay? And they end up in the hospital for that. And then from there, there's an assessment that's done and you end up in supportive living. So we often in the hospital see this, and I just wanted to take you through this a little bit and say, well, how does the transition happen? Well, often we have family members and loved ones calling and saying, listen, where are they going to end up? Where are they going to end up? What do I do? Do I need to sell my house? Do I need to sell the house? Do I need to, if it's in a crisis situation, there's so many concerns. So first thing is first, if the patient's coming in with an acute issue, it has to resolve. You have to know where the dust settles, so to speak. You have to know where the baseline is, the new one. So if someone's still in heart failure, needing 5-10 liters of oxygen, it's still too early, let it resolve. Your attending team will let you know when things are resolved. When we're no longer searching for additional diagnosis to a problem that we see, okay, that's key. And then what happens is there's a rehabilitation team. So once your acute issues are resolved, they're working with the patient. And when they plateau, when there's no longer any more improvement in mobility and functioning, they say, this is the new baseline, new level of care. This is what nursing has to do. This is what so-and-so has to do. Now, can this level of care needs be matched at home with a caregiver and the amount of home care supports we have, or other private assistant or other private supports that the family can work with? So there's a multidisciplinary team that often meets with families and caregivers and sees what can be done. If it's deemed that it's possible to say, sure, you can go back home, but you know what? This may only be temporary. Start thinking about placement. Or if you guys can manage because you have many siblings and private assistants, so on, you can do it at home, then maybe this will be the end point. The patient can go back home, not a problem. But on the flip side, then if it's not sustainable to be at home, this is when they start looking at supportive living and the different levels that we talked about. So again, I want to really reiterate this because I feel like often this is a barrier to why people want to consider a smooth transition. So if a loved one or a patient has to be permanently separated from their family or from their home, okay, I want to make it very clear that this is not a sign of failure at all. And there should be in no way any sense of caregiver guilt or shame. And it's very possible that a loved one who has to be separated may not understand initially why this is to be the case, right? They may not, and they themselves maybe feel bad, but in my experience, everybody eventually ends up appreciating it. When there's a reduction in the level of their caregiver's burnout, when that caregiver ends up changing from having to be their caretaker and looking after others to then providing affection, making use of quality time, it becomes a much more meaningful relationship rather than a business type relationship between the caregiver and loved one, right? It ends up changing everything. When nobody's stressed anymore, when there is good care given in a timely way, everything ends up sorting itself out nicely. In my experience, I've never seen anything end up being bad afterwards. And then both the caregiver and loved one can then foster a healthy aging process beyond just a physical and cognitive dimension, which we just briefly touched on earlier. I think this speaks to, I would say maybe to, our Tarika, that we appreciate that beyond the physical and cognition, there's something else that's very important and that, we all should engage in. And without having all the stress and strain and recurrent hospital visits, perhaps this allows the space for people to do that. So it's a positive thing in many ways. Okay, now moving on to, in summary, what did we talk about? We talked about disease and dysfunction is not a healthy part of healthy physical and cognitive aging. We talked about reserves and dysfunction. How reduced reserves can be reflected by reduction in functioning or increase in care needs. That there exists in every province across the country levels of care that match the level of need somebody has. And then it's important to recognize early warning signs, both of cognitive dysfunction, physical dysfunction, because you can potentially avoid needing to, require supportive living, or you can delay that process. We talked about the importance of having, courageous discussions around sensitive issues, to make a plan to avoid transitioning during a crisis, and then to reach out to community support resources, so home care, and then the one we have in our community, the navigation, they changed the acronym, so I'm so used to calling it MAS, but it's the, maybe this hits at home, Saifa. It's the Health
Navigation Service.
Okay, and I'll put a slide up in a moment. But remember this, okay. Okay, and then, reach out. And then sometimes transitioning to supportive living away from home is inevitable. And in that case, there should be not a sense of guilt or shame. And in many instances can be an opportunity to focus on being affectionate with one another, but also exploring other dimensions of healthy aging. This is a slide for the health navigation. I'll go back to it in a minute, but I do want to say thank you to all those participating. If you are a caregiver or one in need, I hope this helps. And also special thank you personally to Saifa, but to Omid Jamal, who's not here, but she coordinated this presentation on behalf of the Aga Khan Health Board for Canada, the audiovisual and communications team. I think Adil was here just earlier. I think he's in the background somewhere. The guys behind the curtains that we don't see who make this presentation available. And personally to my colleague, Ashif Rahman, my colleague who reviewed and contributed to these slides. So I'll leave it at that, Saifa.
So thank you very much. Thank you on behalf of the Aga Khan Health Board for Canada and the National Care for the Elderly portfolio. I'd like to offer my heartfelt gratitude and thanks to Dr. Naheed Rajabali for an awesome presentation. As an Ismaili, I'm also very proud of Dr. Rajabali that you are one of our own. So thank you, and makes us very proud. And finally, I'd like to thank all of you, our wonderful participants, for being an amazing audience. I mean, good numbers today, so thank you very much. I will now open up the floor for any questions. I do have one question, if nobody else has any questions. Naheed, you talked about, I think one of the key take-home message for me was about the reserves and how important it is when we're younger, is to start building those reserves, and maybe when we're not also so young, to start building those reserves, because they help you fight the disease process, so to speak, right? And also for our Jamaat. I mean, there's so many things you touched upon that are so important that we don't realize. There was one, I think, aspect you talk about: socialization, volunteering, meditation. So all those things that we do in Jamaat Khana and in sometimes a home really help us, and like you said, make those cellular changes to fight the disease process. So I think for me, that was a really good take-home message. Are there any other sort of one message you'd like to give our audience, one take-home message, moral of the story, so to speak?
Yeah, moral of the story. I think it would be just that, is the process of healthy aging is mind, body, spirit. And it's kind of important for all of us to really actively pursue healthy aging in all of these domains, especially living in an environment that may not necessarily value those things. So it's never a late time to engage in any of those aspects. It's never late.
And Naheed, just a comment from somebody in the audience. If you can put the summary slide up, please. And we'll leave that up for a couple minutes. And somebody's asking a question about any Ismaili homes for the aged in Canada. I'm asking this aloud because Naheed was on the board for Generations Calgary last term, I believe. Naheed, do you know of any? We know that Generations Toronto is happening, but any other thoughts about any additional Ismaili homes for the aged coming up? You're on mute, by the way.
Right, sorry about that. No, yes, you mentioned Toronto. I think there's also, one being looked at in Vancouver, right? But yeah, I mean, being on the board, I can tell you that the values are good. Previously being on the board, they do try to foster these aspects that we talk about: mind, body, spirit. But again, there are more, I guess, non-community supportive living centers than there are some. And when you're in a pinch, you may not necessarily be able to go to one that is community, an Ismaili related one. But that doesn't mean that you can't bring your set of good values, the healthy aging and the mind, body, spirit to those places. I think if you can be quote unquote portable with those values, you won't have to worry about where you sort of end up. In fact, I always say this, there's always little, and maybe borrowing a term from Hazri Imam, right? I think he's called some things islands of hope, maybe in one of the speech. If you foster good, values or good, practices, in where you are, you might be that spark that lights those things in those places, right? So it would be nice for all communities to kind of harbor similar sort of healthy aging values that we think we do, foster as a community.
And Naheed, if you can put on the HNS access line slide for some of our participants.
There we go.
And then we can end with that. So just somebody asked about access line and HNS. So you can access the health navigation service through the access line. So the 1-888-536-3599 is the access line number. And then they will send you, like if you can press health on it, it's by numbers, and they will direct you to the health navigation service from the access line. So that's the access line number. And there are no more questions, and our participants would like to thank you, Dr. Rajabali. And thank you again to our participants. Thank you to Dr. Rajabali, and thank you to the II Canada team, and thank you, Yalimadat, and good evening.
Yeah,
thank you. Bye-bye.